Hi, my name is Faisal Kamal. I'm a gastroenterology and hepatology fellow at the University of Tennessee Health Science Center in Memphis, Tennessee. First, on behalf of my co-authors, I would like to thank Gastrointestinal Endoscopy GIE for the opportunity to discuss our recent article entitled Efficacy and Safety of Supplemental Intravenous Lidocaine for Sedation in Gastrointestinal Endoscopic Procedures, Systematic Review and Meta-Analysis of Randomized Controlled Trials. As you all know that sedation is an integral component of successful GI endoscopic procedures. It improves outcomes by increasing patient satisfaction and minimizes the risks of complications by avoiding involuntary movements. With millions of GI endoscopic procedures performed annually, being able to improve outcomes by increasing patient satisfaction while simultaneously minimizing adverse events is crucial. Benzodiazepines, opioids, and propofol are the most commonly used medicines for GI endoscopic procedures. Monitored anesthesia care using propofol has gained popularity and is now the mainstay for sedation in many countries due to its rapid onset of action and rapid recovery. It has a shorter recovery time, better sedation, and greater anesthesia levels than the traditional sedative agents such as benzodiazepines and opioids. Although propofol is typically used alone for monitored anesthesia care, high doses are sometimes required to achieve adequate levels of sedation. But this can increase the risks of respiratory depression and cardiovascular complications. In a randomized controlled trial, Forster and colleagues compared the combination of intravenous lidocaine and propofol with intravenous propofol and saline. The combination of intravenous lidocaine with propofol resulted in a 50% reduction in the dose requirement of the propofol, and it also improved post-colonoscopy pain and fatigue. A few other randomized controlled trials evaluating the safety and efficacy of intravenous lidocaine in GI endoscopy procedures have also reported favorable results. The propofol sparing effect of the lidocaine has previously been observed in surgical procedures, and it is thought to be mediated through its anti-nociceptive actions rather than a hypnotic effect. To evaluate this propofol sparing effect of lidocaine and also its safety in the GI endoscopic procedures, we conducted a systematic review and meta-analysis of the randomized controlled trials. For this meta-analysis, our primary outcome of interest was the difference in the dose of propofol administered between the intravenous lidocaine plus propofol group and the propofol plus placebo group. Our secondary outcomes of interest were the procedure time and the procedural adverse events. We performed subgroup analysis, including colonoscopy studies only. We also performed subgroup analysis based on the dosing of intravenous lidocaine. In the final analysis, we included a total of 5 studies with 318 patients. Of these, 158 patients received propofol and lidocaine, and 160 patients received propofol plus placebo. We found a statistically significant reduction in the total dose of propofol administered in the lidocaine group compared to the control group. The standardized mean difference was minus 0.76 with 95% confidence interval of minus 1.09 to 2.42. We found no significant difference in the procedure time or in the risks of procedural adverse events between the two groups. Our results remained unchanged in all subgroup analyses. We noticed moderate to substantial heterogeneity in the data. The certainty of evidence ranged from low to moderate based on GRADE framework. 2 of the studies included in our meta-analysis also compared the post-procedure pain and fatigue between the groups and found that these were significantly lower in the lidocaine group. In conclusion, we found that the intravenous lidocaine was beneficial in reducing the dose requirement of propofol in GI endoscopic procedures. We cannot recommend changes in practice at this time based on the results of this meta-analysis due to its limitations of small sample size and heterogeneity. However, our novel findings should stimulate further research that may potentially change for future sedation and anesthesia practices for endoscopy. Future large multi-center randomized controlled trials with standardized anesthesia protocols would be required to make any firm conclusions. I once again thank GIE for giving me the opportunity to present our work. I also thank you for watching this video. I hope you will find our article interesting and useful in your current practice.